Hello everyone, and in this video I'll be discussing the drugs used in bronchial asthma. So it is pharmacotherapy of bronchial asthma. Now you all know the reason for asthma. There is a triggering factor, that is allergen. So suppose the patient gets exposed to dust, mite, pollen. So there is bronchoconstriction. So patient come with cough, wheezing, difficulty in breathing. So what we call it as acute attack of asthma. So in managing any asthma, there are two concepts I need to understand. Number one, whenever the patient comes with acute attack, that is wheezing, bronchoconstriction, I use certain drugs called bronchodilators. Second important aspect is I don't want the patient to get attacks repeatedly. So I want to prevent attacks. So I use a drugs called prophylactic drugs for asthma. So in this topic, we will be discussing what are the drugs which we use during attack and which are the drugs we use for prophylaxis of asthma. So let us start our journey, bronchial asthma. Let us start with pathophysiology and then come to the drugs. Let's start. So as I told you earlier, the triggering factor for asthma is allergen. So allergen may be dust, mite, pollen. So whenever the patient gets exposed to allergen, there is activation of the immunoglobulin, that is called IgE. Now this IgE will come and sit on the mast cell. So this is the mast cell. So this mast cell undergoes degranulation. So when it undergoes degranulation, the mast cell will release the inflammatory mediators. For example, histamine. It will release prostaglandins. It will release leukotrienes. So at the site of this thing, inflammatory response, there is arrival of eosinophils. There is release of interleukins at the site of the inflammation. Now all this contribute to what we call it as the bronchoconstriction. So that is what we mean by acute attack of asthma. So patient will have bronchoconstriction, increase in mucus production. That is what happens. So the drugs which we use to treat bronchoconstriction, they are called as bronchodilators. So they are called as bronchodilators. Bronchodilators are also called by a name, that is relievers. Now why they are called as relievers? Because they relieve the asthma symptom. They cause bronchodilation and relieve the wheezing, cough and all those things. Now any drug which act above this line, what are they? They are called as prophylactic drugs. So what do you mean by prophylaxis? They prevent the attack of asthma. These prophylactic drugs are also called as controllers. Now why they are called as controllers? Because they control the attacks. That's why. So let us first discuss about controllers or the drugs for prophylaxis. Then we'll go to the relievers. Now you pause the video and just analyze what are the targets for us so that we can stop the allergic manifestation and stop the inflammatory process. Number one, patient education. So tell the patient not to get exposed to the allergen. Second, block the immunoglobulin, that is IgE. Number three, stabilize the mast cell. Tell the mast cell to keep quiet. Now can we do something with histamine? No. Antihistamines are not so much effective in asthma, so antihistamines don't have any role in asthma. What about prostaglandins? Some prostaglandins are dilators, some are constrictors of bronchus, so we cannot block them. So what we can do is we can block the leukotrienes. Number 5, you can also block the interleukins. Number 6, we have drugs called steroids, and you know that steroids are anti-inflammatory drugs. So these are the drugs what we can use as prophylactics of asthma. So let us discuss one by one. First one. Number 1, avoidance of allergen. Avoidance of allergen. So patient education is the most important thing. Second is Ig. So block it. Block the Ig. And the drug which blocks Ig is omalizumab. The name is omalizumab. Remember, any drug ending with mab, it's a monoclonal antibody and we cannot give them orally because they are proteins. So if I want to give it, the drug is given by the route subcutaneous. And where to use it? The drug is used in two conditions. One is allergy. Second, we can use it in bronchial asthma. The frequently asked question in the exam is, can we use it in acute attack of asthma, omalizumab? No, it's only for prophylactic therapy. It's an injection. Moving on to the third target. These are called as mast cell stabilizers. As the name suggests, they stabilize the mast cell and they don't allow the mast cell to degranulate. What happens if it degranulates? The inflammatory mediators come to the picture and they can cause bronchoconstriction. So that is avoided. So there are two important mast cell stabilizers. Number one, you can give it by inhalation. So the drugs can be given by inhalation route, or you can give them by oral route. The drug which is given by inhalation route, its name is called sodium. It is called sodium chromoglycate. The name is sodium chromoglycate. One more drug name is nidocromel, and they are given by inhalation route. So if you know omalizumab, you have chroma here, chromoglycate, nidocromel. The orally available drug, the name is called ketotifen. Ketotifen. Please mark this point. Most of the examiner have asked this question. Can we use sodium chromoglycate in acute attack asthma? Never. It's only for prophylaxis. Why the confusion? Because it is given by inhalation. That's why most of the students confuse this. It's only for prophylactic only. Now once we are done with that, number 4, we have certain drugs called leukotriene receptor antagonist. Two major drugs what we have is montelukast and a drug called zafirlukast. If you observe their name end with lukast. That is the specialty. Now, where do I use them? They are used for allergy. They are used for bronchial asthma. Please remember, again, the most common question for montelukast is mechanism of action. Second question is it used in acute attack? No, it's only for prophylaxis. And one advantage is it has steroid sparing property. So usually to control asthma, we used to give oral steroid. Since the introduction of montelukast, the steroid requirement has come down, so we can start montelukast only. Any problem with these drugs? The adverse effect is they have shown to increase liver enzymes in certain people, and there is a rare adverse effect what we see with this drug, and that is called drug Strauss syndrome. It's not a common problem, but it's a rare adverse effect what we see with leukotriene receptor antagonist. Number 5, what we have is the steroids. So I'll discuss the interleukin later. I will take up steroid. Interleukin will be discussed under newer drugs, don't worry. So the fifth target is steroids. Now, what is the role of steroid? Let me explain to you. Now, you all know that there is something called membrane phospholipid. From the membrane phospholipid, we get something called arachidonic acid. And the enzyme which convert that is called phospholipase A2. So this arachidonic acid is acted upon by two enzymes. One is called the COX, which will give rise to prostaglandins, and LOX stands for lipoxygenase, which will give rise to leukotrienes. So leukotrienes, we have C4, D4, which are responsible for bronchoconstriction. B4 is responsible for chemotaxis. So this is the point. What happens when the inflammation starts? There is bronchoconstriction. Suppose you want to stop this inflammation, what I can do is, when I use steroids produce something called annexin 1. This annexin 1 inhibits phospholipase A2. That is one thing. If I use a COX inhibitor, sometimes the asthma gets triggered. Reason is, when you inhibit COX, the arachidonic acid gets diverted towards LOX, leukotrienes are produced, and that will cause bronchoconstriction. Particularly, there is a condition called aspirin induced asthma in certain people. So you know that aspirin is a COX inhibitor. By inhibiting COX, it can trigger asthma. Not only that, some of the NSAIDs can also cause this asthma attack. So you should be very careful when you are using NSAID in an asthma patient. But remember, the safest NSAID in asthma patient will be paracetamol. Clear? So steroids, this is their mechanism of action. So guys, we have already discussed the leukotriene receptor antagonist. The name is montelukast and zafirlukast. Can I inhibit the LOX enzyme? Yes. This can be inhibited by a drug by the name xylitol. So we have one more prophylactic drug. I can coin it as sixth drug. The name is xylitol, which inhibits LOX. So we call it as 5-LOX. And one of the common problem with this is the drug is shown to be hepatotoxic. The drug is hepatotoxic, that is xylitol. So we understood the mechanism of action of steroids. Okay, so moving on to another group of drugs in asthma. I told you they are called steroids. Now steroids can be administered in 3 ways. What are the 3 ways? We can give them by inhalation route. We can give the steroids by oral route, or we can give the steroids by intravenous route. Yes. Now, inhalation steroids are also called as inhaled corticosteroid. It is written as ICS. So what are the drugs in that? The drugs are called beclomethasone. So B for beclomethasone. And one more drug which has the same thing. It is called budesonide. The name is budesonide. Then we have a drug by the name fluticasone. And one more is flunisolide. And we have mometasone. And one more is called cyclesonide. These are all inhaled corticosteroids. Now you know that in COVID-19, most of them were advised to take budesonide. Now this cyclesonide is also called as soft steroid. So what do you mean by soft steroid? Now we tell the patient to take it by inhalation. When it is taken through inhalation route, many a times what happens? They reach the lung. Many a times they are also swallowed. When they are swallowed, they are absorbed systemically and they can cause adverse effect. The advantage of cyclesonide is when you inhale, it is a prodrug and it is activated only by the esterases in the lung. Even if it is swallowed, it is not getting activated and it will not get systemically absorbed. So the advantage of soft steroid is lesser systemic adverse effect, and that is seen with cyclesonide because it's a prodrug activated by the esterases in the lung, so it will produce a local action in the lung and it has less systemic absorption. Whenever we give inhalation steroid, either we give it by meter dose inhaler or by dry podal inhaler, the problem is they get deposited in the throat. Because of that, the patient developed two problems. One is dysphonia and a problem called oral candidiasis. So the adverse effect what we see with that is the oral candidiasis. So how do we prevent this problem of oral candidiasis and dysphonia? Simple measure. Once these are inhaled, it is better to do gargling. A simple mouthwash or a gargling will remove that deposition. Second important is use of spacers. So if the patient develops oral candidiasis, then we have to give antifungal drug topically. Examples are nystatin or we use clotrimazole. Then we can also give the steroids orally. The steroids what we give orally are prednisolone. If you add methyl, the drugs become methylprednisolone. The problem with oral steroid is they cause long-term adverse effect. So they are only used in persistent severe asthma. So they should be used in the last stage, not in the early stage, because of their systemic adverse effect. Now the IV drugs which can be used are hydrocortisone, and methylprednisolone. So methylprednisolone. Now remember, these IV drugs are used in the management of a condition called status asthmaticus or acute attack of asthma. Now what is the advantage? They are not bronchodilators, then why are we using it? Steroids are known to increase the beta 2 response. So what is the problem in attack of asthma? The beta 2 are not working properly. If they work properly, the bronchus will dilate. So the beta 2 response is increased by these corticosteroids, and that's the reason why we add them in these patients. So these are the steroids: inhalation, oral as well as IV steroids. Next I will be discussing the bronchodilators. So what is the other name I told for bronchodilators? They are also called as relievers. Okay. So how do you dilate a bronchus? So let me draw a bronchus for you. So this is the bronchus. Right. So the bronchus has a receptor called beta 2. So you all know that beta 2 is a GS coupled receptor, and that will act by increasing cyclic AMP. So the cyclic AMP will cause bronchodilation. But this cyclic AMP is broken down into 5-AMP by the enzyme phosphodiesterase. Another one which is there in the bronchus is a receptor called M3. So M3 is a GQ coupled receptor, and you know that they act through IP3-DAG pathway. So because of that, they cause smooth muscle contraction, that is bronchoconstriction. There is also entry of calcium which helps in bronchoconstriction. Now look into this image and tell me the targets where I can cause bronchodilation. Can you tell me that? Whom should I stimulate? Whom should I inhibit? So number one, I can stimulate beta. So if I stimulate beta 2, that will lead to bronchodilation. Now second, what should I do? I should not stimulate M3 because that will cause bronchoconstriction, so I should block M3. Now who is going to cause bronchodilation is cyclic AMP. Make it longer acting. How do I do that? by inhibiting phosphodiesterase. So that is the third target what we have. And the drugs are called as methyl xanthines. And one more exciting is don't allow the entry of calcium, and the calcium channel entry is blocked by a drug called magnesium sulfate. So it's also a bronchodilator. So we have 4 basic bronchodilators used in asthma. Let us discuss one by one. So number 1, we have the beta 2 agonist. So in beta 2 agonist, we have something called SABA. Now what do you mean by SABA? SABA stands for short acting beta 2 agonist. Examples are salbutamol, and one more drug is terbutaline. So we have the SABA drugs, salbutamol and terbutaline. They are very short acting. They will work for 4 hours or 5 hours. So patient has to take 4 times a day. Now what is the adverse effect of this salbutamol? The adverse effect of salbutamol you can remember as 2H and 3T. So what are the 2H? The 2H are, it is known to produce hyperglycemia. So it will increase the glucose, but it causes hypokalemia. So that is the adverse effect of salbutamol and terbutaline because of beta 2 agonism. You may ask a question, sir, can we use salbutamol for managing hyperkalemia? Yes, salbutamol can be used to manage hyperkalemia also, but how do we give that? By nebulization. What are the 3T? What are the 3T we see with this? The 3T is patient will develop tachycardia when he is taking salbutamol or terbutaline. Second, patient may develop tremors. And number 3, if you give the drug repeatedly, patient will develop tolerance. What do you mean by tolerance? Tolerance means if I am using 1 milligram, there is bronchodilation. If I use it continuously, what happens after some day, with 1 milligram, the bronchodilation will not occur. So that is tolerance. So the meaning is you cannot use beta 2 agonist repeatedly to a patient. So patient cannot take salbutamol every day. Either you have to increase the dose, but if you increase the dose, the adverse effect increases. So the reason for tolerance is beta 2 will undergo desensitization. Right. So that is about the salbutamol. So salbutamol can also be used apart from asthma. It is also used to treat hyperkalemia. Since these drugs are very short acting, we had to come up with one more concept, that is longer acting beta 2 agonist. So the next one are LABA. LABA stands for long acting beta 2 agonist. So the drug name is formoterol, and one more is salmeterol. So remember as motor and meter. So if you have motorcycle, you can go kilometers, that is longer. Now another important aspect is F for fast onset. The drug has fast onset. Salmeterol has slow onset. What do you mean by onset? Onset means when I take a drug, and after taking the drug, after how many hours or how many minutes or how many seconds the drug starts working. That is called onset of action. Suppose there is an attack of asthma, which one is better, formoterol or salmeterol? Obviously formoterol, because it has fast onset of action. But remember, these drugs, they can work for 12 hours. So you have to give 2 times in a day. Now, what happens in practice? Suppose you want to give beta blockers every day. Formoterol, you want to use it. What is formoterol or salmeterol? They are LABA. So LABA you should not use alone. Alone not used for long periods. Why? Why don't we use it alone for long period? Because they develop tolerance, then they will not work. So if you want to use LABA for long periods, you should always use with ICS. ICS stands for inhaled corticosteroids. Now when you use LABA, what is the problem? There is decrease in, or I can write like this, beta 2 will undergo desensitization. But what does inhaled corticosteroid will do? They increase beta 2 sensitivity. That means they increase beta 2 response. So the tolerance problem will not develop when I use them together. Never use LABA alone for long periods. If you want to use them, always use them with inhaled corticosteroid. So another question which comes again and again is, can we use inhaled corticosteroid alone? Yes, you can use them, no problem, but never use LABA alone. So that is about the beta 2 agonist, SABA and LABA. Clear? Yeah. The next bronchodilator what I am going to discuss is the muscarinic antagonist. So the name is muscarinic antagonist. So it is also called as SAMA. So you tell me what is the full form of SAMA? Short acting muscarinic antagonist. So the drug name is ipratropium bromide. The name of the drug is ipratropium bromide. The problem here is you have to give it minimum 4 times a day. It's very shorter acting. And this ipratropium bromide, where to use it? It is mainly used for COPD more than bronchial asthma. The reason is in COPD the larger bronchioles are affected. Larger bronchioles are affected, and it is because of high cholinergic tone. So that's why we use anticholinergic drug like ipratropium. But in asthma, the smaller bronchioles are involved, so beta 2 agonists are better for asthma. Clear? Yes. So these are used for COPD more than bronchial asthma. Now what is the adverse effect of ipratropium bromide? Let me tell you that. The adverse effect of ipratropium bromide is it can produce bitter taste. So when they take it inhalation, there is a chance it produces bitter taste. Second, it can produce a problem called paradoxical bronchoconstriction. Sir, we are discussing dilators, then how come it is a bronchoconstrictor? That's a question. So we all know that sun rises from the east, but when the sun rises from the west, that's a paradox. So how come it produces bronchoconstriction is a big question. Now there is a theory explained for this. There are 2 theories to explain paradoxical bronchoconstriction. Number 1, due to preservatives. Due to preservative. The preservative that is used is called benzalkonium and EDTA. So when we give the drug as nebulization or inhalation, there is a chance that these can irritate the bronchus and cause bronchoconstriction. That is one theory. Second theory is by inhibiting presynaptic mTOR receptor. Sir, how come that will help? How do you explain that? I will take a diagram for it. Now this is the synapse. This is the synapse. You all know it. Now before I come to the synapse, what is the role of acetylcholine? Acetylcholine acts on M3 receptor, and you know that it is responsible for bronchoconstriction. The cholinergic causes bronchoconstriction. You all know it. Yes. Now, In the presynaptic terminal, we have a receptor called M2. In the presynaptic terminal, we have M2. The role of M2 is to decrease acetylcholine release. I think it's similar to the alpha-2 action. M2 also does the same thing, it decreases acetylcholine, but alpha-2 decreases normal release. Now, when I use a drug called ipratropium, what does it do? Ipratropium blocks this presynaptic M2 also. What happens if it blocks presynaptic M2? Then acetylcholine will get released. This acetylcholine acts on M3 receptor and that will cause bronchoconstriction, and that is what we call it as paradoxical bronchoconstriction. That is one problem what we face with ipratropium bromide, and the second problem is it's very shorter acting. To overcome this problem, we came with another category. They are called LAMA. LAMA, you know that it stands for long-acting muscarinic antagonist. LAMA, they have no paradoxical bronchoconstriction. And they are longer acting. Long acting means you can give once daily also. Example is tiotropium bromide. Then we have glycopyrronium bromide. Then umeclidinium bromide. So these are the drugs. So major use of these drugs in mainly for, so Rx if I write, it is the use COPD. What is the adverse effect? The adverse effect of the drug is, obviously it's an anticholinergic drug, so dryness of mouth. And in some elderly population, it is known to produce urine retention. So these are the problems with these drugs. The name is LAMA, tiotropium, glycopyrronium, imeclidinium. These are the drugs. They don't produce paradoxical bronchoconstriction and they are longer acting drugs. The next bronchodilator which we are going to discuss, number 3, they are called as methylxanthines. They are called as methylxanthines. Two major drugs what we have is, one is called aminophylline and one more drug is called theophylline. So theophylline, I told you, we require therapeutic drug monitoring and the level should be maintained between 5 to 15 milligram per liter. That is a therapeutic index. Within that you have to give the drug. Now methylxanthines, what is their mechanism of action? How do they work? So let me write the mechanism of action. Mechanism of action, the major mechanism of action is this. They inhibit the enzyme phosphodiesterase. They inhibit the enzyme phosphodiesterase. Second, they inhibit a receptor called adenosine. So when they inhibit the adenosine, these are responsible for bronchodilation. Another important mechanisms is this. They increase interleukin 10 release. They decrease inflammatory genes. So they are known to decrease inflammatory genes. And also they do one more thing, that is histone deacetylase activation. So these contribute for their anti-inflammatory property apart from bronchodilating. So major action is by inhibiting phosphodiesterase, they increase cyclic AMP. Adenosine is a bronchoconstrictor. They block adenosine receptor and cause bronchodilation. So they also have anti-inflammatory property. They increase interleukin 10. They decrease the inflammatory genes which are expressed in asthma, and also they cause histone deacetylase activation. So once we understood the mechanism, where do we use this methylxanthines? Now aminophylline is given IV and the IV preparation is used in attack of asthma. So even though the usage has been not so common nowadays, but you can use it IV for attack of asthma, that is status asthmaticus. Then theophylline is used for mild asthma and severe cases of COPD. So this is the indications of methylxanthines. What are the adverse effects? So let us understand the adverse effect of methylxanthines. I want you to just imagine that you have taken 10 cups of coffee or 10 cups of tea. Then what happens to your system, that is body? Because caffeine, theophylline, the tea, they are all nothing but methylxanthines. So what happens when you have taken so much of tea? What happens to your CNS? In the CNS, it is responsible for CNS activation and that will cause seizures. So high levels of methylxanthine can cause seizures and they can cause behavior abnormalities. Now tell me what happens in CVS. So when you drink 10 cups of coffee, what happens? Heart rate increases. So when the heart rate increases, it may lead to arrhythmia. It will lead to arrhythmia. What happens in kidneys? So when you drink so much of tea or coffee, obviously it will lead to diuresis. Remember, the reason why the seizure occurs is because of adenosine blockade. Why diuresis occurs is also because of adenosine blockade. And why arrhythmia occurs is also because of adenosine blockade. Not only that, it also blocks phosphodiesterase 3 in the heart. So this was a question asked in one of your recent exam. What is the reason for this adverse effect? Why the behavioral abnormalities occurs? The cause is unknown. That is still under study. What are the other adverse effects? What we see when we drink excess of tea or coffee? So it will lead to gastritis, nausea, vomiting, headache. And these are due to what? What is the mechanism for that? It's because of phosphodiesterase 4 inhibition. So the adverse effect and the mechanism is also being asked in the exam. That's why this is being dealt in detail for you. So that is about methylxanthines. Now moving on to the fourth bronchodilator, and the name is called magnesium sulfate. Now what is the mechanism of action? I told you magnesium sulfate blocks the calcium entry. If the calcium doesn't enter, no smooth muscle contraction, no bronchoconstriction. So magnesium sulfate can be given either IV or by nebulization during attack of asthma. So it is used during acute attack of asthma. So until now, I have explained to you what are the drugs for prophylaxis and what are the drugs for the attack of asthma. Prophylaxis I have explained. For acute attack, we use bronchodilators. Number 1, beta agonist, SABA and LABA. Muscarinic antagonist, SAMA and LAMA. Then methylxanthines and magnesium sulfate. These are the drugs. One more important emergencies is something called status asthmaticus. So it's a condition where the patient comes with difficulty in breathing, coughing, hypoxia, right? And he will be using accessory muscles of respiration. So he is under difficulty, so bronchoconstriction. Then what are the treatment for this? So what we use is salbutamol. So salbutamol is given in the form of nebulization. Then we give oxygen. Remember, we should not use dry air because dry air itself irritates the bronchus and cough will increase. So what we use is humidified 100% oxygen. Then we use hydrocortisone. Then we use hydrocortisone. Now we know that steroids are not bronchodilators, then why are we using it in an attack? I told you they increase beta 2 response. That is one reason. And second reason is they decrease the inflammation. Then we also add ipratropium bromide. So ipratropium is known to dilate the larger bronchioles, and it is also given by nebulization, and hydrocortisone is given by intravenous route. Then sometimes we also add terbutaline. Now terbutaline is given by subcutaneous route. Sir, when we are given salbutamol by nebulization, why are we giving terbutaline? Reason is when we give nebulization, there is a chance that the drug may not reach the lower alveoli because of mucus everywhere. So that time bronchodilation will not occur. So what we gave is terbutaline, which can reach the lower alveoli. That's the reason. Along with that, we add antibiotics. Why do we add antibiotics? Because the triggering for attack of asthma is an infection. So we have to treat it. And patient will have acidosis. And the acidosis is managed by giving sodium bicarbonate. So these are the drugs what we use in acute attack of asthma. So you have a mnemonic for that. Whenever there is acute attack, so hit the asthma. So the drugs are like this. S for salbutamol, oxygen, hydrocortisone IV, ipratropium, terbutaline, and antibiotics, and treat acidosis by using sodium bicarbonate. So do we use magnesium sulfate also? Yes, magnesium sulfate is also used, but it's a reserve drug. If these drugs don't work, then we can go give. And also one more drug that is reserved is aminophylline. So these are reserved drugs. We don't use them routinely, but if it is refractory cases, then we go for that. So that is about drugs for status asthmaticus. Moving on to the newer drugs. Newer drugs used in asthma as well as COPD. Let me give the idea. So we have interleukin 5 antagonist. So interleukin 5 antagonist, they are reslizumab, then brenlizumab, and one more is called mepolizumab. So these are not for attack, they are used in severe eosinophilic asthma patients. Since they are a mAb, they are given as injections. That's the reason. Now, is there any new drug for COPD? Yes. We have a M3 antagonist for COPD. What is the name? Any idea? The name is called revafenacin. Then we have a phosphodiesterase 4 inhibitor. We have a phosphodiesterase 4 inhibitor. The name is called roflumilast. It is called as roflumilast. Then we have VLABA. You may ask a question, sir, what is VLABA? It is nothing but very long-acting beta agonist. So the name is indecterol. Then vilanterol. So these are the recent drugs for approved for COPD management. Right? So with that, I have completed the drugs used in asthma. Please remember what are used for prophylaxis, what are used for attacks. And I have explained the things. And remember the adverse effect of salbutamol, very, very important. Thank you all.